Welcome students to the session on organophosphorus poisoning. Organophosphorus compounds are very commonly used in agriculture as insecticides. We have products like malathion, parathion, chlorpyrifos, diazinon, and then you have highly toxic nerve gases which are used for chemical warfare like tabun, sarin, soman. They are used for bioterrorism. As all of you know, organophosphorus compounds, they are potent, irreversible anticholinesterase. So they are inhibitors of cholinesterase enzyme. So this poisoning could be occupational, you know, in case of the person spraying pesticides in the fields, accidental consumption of, plant products which are sprayed by the pesticides, suicidal, intentional ingestion of the organophosphorus compounds or homicidal reasons. These organophosphorus compounds, they are quaternary ammonium compounds and hence they are highly lipid soluble. They are absorbed by all routes. They can be absorbed to the GIT, they can be absorbed to the skin, even intact skin. They can be absorbed to the lungs, etc. And they can even cross the blood-brain barrier and produce CNS effects. So, as I've told you, they are reversible inhibitors of cholinesterase enzyme. So here you have the presynaptic cholinergic neuron where acetylcholine is released into the synaptic cleft. So this acetylcholine can go and bind to the cholinergic receptors, produce its action, and then it is usually degraded or metabolized by the enzyme cholinesterase. Okay, so what happens with organophosphorus compounds is they inhibit the enzyme acetylcholinesterase. They are irreversible inhibitor of acetylcholinesterase and hence acetylcholine is now degraded. So there is increased concentration of acetylcholine leading to increased parasympathetic stimulation. They will stimulate the cholinergic receptors and leading to parasympathetic activity. So what are the manifestations of organophosphorus poisoning? So initially there will be manifestation symptoms of muscarinic excess. So we will be having symptoms like meiosis or pinpoint pupil, diarrhea, urination, bronchoconstriction, lacrimation, salivation, sweating, bradycardia, hypotension, etc. Which will be usually followed by the central effects and the nicotinic effects. So central effects will be restlessness, tremors, convulsions, ataxia, respiratory arrest, and nicotinic effects like vesiculations, twitching, generalized weakness, and depolarization type of paralysis can be seen. It can also lead to delayed effects. The effects can be seen after 1 or 2 weeks, and chronic exposure of organophosphorus compounds can lead to demyelination of the nerves. So for students, it is very easy to remember the manifestations of OP poisoning or organophosphorus poisoning. Just remember the mnemonic dumbbell. Okay, D stands for diarrhea, U for urination, M for meiosis, muscular weakness, B for bronchospasm, bradycardia, E for emesis, excitement, L for lacrimation, S for sweating, salivation, and secretions. Okay. So coming to the management of organophosphorus compound poisoning, according to WHO, the treatment should be instituted rapidly to prevent fatal outcome. So first approach should be ABC. So you have to make the patient lie down in the prone position, clear the mouth and throat, and provide adequate ventilation. Maintain patent airway and maintain the BP and provide circulatory support. You can give diazepam and control the convulsions, and supportive measures such as oxygen can be given, treatment of shock, and prophylactic antibiotics. Decontamination can be done, that we can prevent the further exposure by removing the soiled clothes. You can wash the skin and eyes for almost 10 minutes, and gastric lavage can be attempted if the patient comes to the hospital within 1 hour after ingesting the compound. And healthcare providers should wear appropriate PPE like mask and gloves, because the organophosphorus compounds, they are highly lipid soluble. They can be absorbed through even the skin to prevent any exposure. Coming to the treatment of anticholinesterase poisoning, the specific antidotes are atropine and oximes. The mainstay of treatment is atropine. Atropine is an anti-muscarinic drug. It can be given in the dosage of 2 to 4 milligram IV, bolus IV, repeated every 5 minutes till atropinization. Oximes can also be given, even though there is debate about the effectiveness of oximes in organophosphorus poisoning. Oximes can be given pralidoxime, slow IV injection in a dose of 1 to 2 grams, or 250 milligrams of obidoxime can be given. So the mainstay of treatment is atropine. So atropine is an anti-muscarinic drug. They are very effective in counteracting central and peripheral muscarinic symptoms. Dose of atropine is 2 to 4 milligram IV given as bolus, repeated every 5 minutes. Up to 200 milligram can be administered per day. And after that, maintenance dose may be required for 2 to 5 days. So it is considered as a first choice drug. Being an anti-muscarinic agent, it does not reverse ganglionic action and neuromuscular paralysis. So atropine should be given by IV bolus or intravenous infusion till we achieve the atropine targets. So let's see what are the atropine targets. And the heart rate is more than 18 per minute. BP is more than 80 millimeters of mercury. And the chest should be clear on auscultation. There should be no bronchoria or bronchospasm. And the pupil should not be pinpoint. After that, you can give maintenance dose for 2 to 5 days. More about atropine we'll be learning in the next section. Now coming to oximes. Oximes are cholinesterase reactivators. So what are the drugs? We have pralidoxime, we have obidoxime and diacetyl monoxide. So what do? They are capable of regenerating the active enzyme from the organophosphorus cholinesterase complex. So they are mainly used to restore the neuromuscular transmission. So drugs usually pralidoxime is given as slow IV injection in the dose of 1 to 2 grams, and the treatment should be started as early as possible before the aging happens. And it should not be used before atropine. Atropine should be always the first choice of drug in organophosphorus poisoning. So this is the structure of oximes or cholinesterase reactivators. We have pralidoxime. This is pralidoxime, then this is diacetyl monoxide. Now, let's just brush up about acetylcholine and how it is degraded. So, acetylcholine is metabolized by the enzyme acetylcholinesterase. So, this acetylcholinesterase has two sides. You have the anionic side and the esteratic side. So, acetylcholine, this is the structure of acetylcholine, will go and bind to the acetylcholinesterase enzyme. Okay, so this by electrostatic attraction, the quaternary ammonium will go and bind to the anionic side, and this carbon atom will go and bind to the esteratic side. Okay, after binding, this it is reversible in milliseconds. That is why acetylcholine is rapid acting, or it has an evanescent action. It is metabolized to form acetic acid and choline. Now, coming to organophosphorus compounds. These are the organophosphorus compounds: diflos, parathion, epothiopate, etc. So you have the acetylcholine esterase enzyme here. You have the anionic side and the esteratic side. And this organophosphorus compounds, why are they called organophosphorus compounds? Because they have a phosphorus atom in their structure. Okay, so you have a labile group here in yellow. So this organophosphorus compounds will go and bind to the esteratic site, leaving the anionic site vacant. Always remember that. So after binding, they will this labile group will cleave off, and this esteratic site get phosphorylated. Okay, so once this organophosphorus compound, the phosphate group binds to the esteratic site, We can call it a phosphorylated cholinesterase enzyme. This cholinesterase enzyme is phosphorylated. So, by phosphate group, by a covalent bond, it is bound to the esteratic site. After binding, it becomes highly stable. Okay, and this phosphorylated cholinesterase enzyme can undergo what is called as aging. They undergo a molecular rearrangement within 1 or 2 hours of binding. They will that 1 or 2 alkyl group will be removed, and they become highly resistant to hydrolysis. So that is called as aging. So what happens when you give oximes? So you can see the phosphorylated cholinesterase enzyme here, and then you have the pralidoxime. So pralidoxime will go and bind to the, you know, this anionic site which is vacant after the cholinesterase is phosphorylated. This is the phosphorylated cholinesterase, and the anionic site is vacant. Pralidoxime will go and bind to it. So this oxime molecule, that NOH of oxime, has high affinity for this phosphorus atom. Okay, so what will happen? Oxime phosphonate complex will form. Okay, so once this oxime phosphonate complex is formed, it diffuses out, leading this cholinesterase enzyme, which will be reactivated. Okay, so once again, you can see the cholinesterase enzyme here. The anionic site is vacant. Acidic site, you have the, opica organophosphorus compound, which is bound, phosphorylated. So this vacant anionic site, your pralidoxime will bind. This NOH of oxime has high affinity for phosphate. They will bind, leading to the formation of oxime phosphonate complex. Once it is formed, it will diffuse out, and it will leave the cholinesterase enzyme regenerated. That's the mechanism of action of oximes. Coming to the adverse effects of oximes, it can lead to local irritation, drowsiness, giddiness, blurred vision, diplopia, tachycardia, and hypotension. And obidoxime is hepatotoxic. Let's see the shortcomings of oximes. Oximes should be started as early as possible. Reactivation is not possible after aging. I told you what is aging. After 1 or 2 hours of uh, cholinesterase drug complex is formed, they undergo a molecular rearrangement and they become resistant to hydrolysis. After this aging, reactivation is not possible. And pralidoxime has weak anticholinesterase activity, and hence it is contraindicated in the treatment of neostigmine and physostigmine overdosage. They are also contraindicated in carbamate anticholinesterase poisoning also, like Baygon and Carver. With that, we come to the end of the treatment of organophosphorus compound poisoning. Thank you for listening.